In terms of authorization of drugs, really there is no difference in terms of the prior authorization process based on route of administration, frequency of administration. We realize that as treatment paradigms have evolved over the last few years, they become very complex, and you'll see patients start on an oral and then move to an IV and then use a sub-Q and an oral. And so we have to be prepared to view the holistic treatment approach to the patient and not get bogged down in, well, this is a medical benefit, this is a pharmacy benefit, this is an IV, this is self-administered. One of the advantages we have at Humana is we've always owned our own PBM, so we've had the ability to have that visibility over both medical and pharmacy benefits. Ultimately, I think we also need to put ourselves in the shoes of the clinician. Physicians typically say a drug is a drug, and some are IV, and some are sub-Q, and some are PO. And so some of this artificial differentiation that you see in terms of medical and pharmacy benefit is not going to be helpful to the clinician in terms of making his or her decision. At Humana, our medical policies obviously reflect whether a drug is self-administered or administered by a healthcare professional, but the process of developing that prior authorization based on the evidence-based literature, the FDA label, the current standard of care, that's going to be the same regardless of the mode of administration or the route or the dosing or any of those secondary elements.
Patients with pulmonary hypertension are often very challenged on multiple fronts. First, they're receiving a diagnosis that can be life-threatening. So the psychological impact of that to them and their loved ones is quite significant. And if you evaluate that objectively, it's quite prevalent, patients in pulmonary hypertension to be struggling on that front. Secondly, if they're on medication for the pulmonary hypertension, all of these medications have something in the way of side effects. Can be very mild in certain circumstances or easily controlled with certain strategies, but they can be quite significant and affect the quality of life in and of themselves just with the burden of therapy with the side effects. The second category of burden of therapy is expense. Healthcare is expensive. And just at a high level, the United States, approaches $4 trillion annually in healthcare. Prescription medications are in the $400 billion range. Specialty medications like those for cancer or pulmonary hypertension are an ever-increasing percentage of that prescription medication. And pulmonary hypertension medications are often expensive. Almost all of them require a prior authorization through their insurance companies. There's issues even with approval by the insurance company of copays. The copays may be significant. We've done some recent survey data with our patients and also at the Pulmonary Hypertension Conference showing that the reality of the burden of getting these medications paid for and strategies that patients might employ to try to mitigate that expense are significant burdens in and of themselves. They ask for assistance programs from the pharmaceutical companies, which might be available. They may apply for assistance programs for the Pulmonary Hypertension Association, which might be available. Some patients have skipped doses of medications to try to make them last longer, which of course is far from ideal when you're treating a life-threatening illness. And really this can be, quite challenging to the patient. The last thing I would say is that we know patients with pulmonary hypertension are also often deconditioned. Because they've had shortness of breath and limitation of their activity, it's easy for them to lose muscle tone, to lose conditioning. And so formal exercise programs, for example, pulmonary rehabilitation, can help the patient gain back some functional status, some conditioning. They're able to do more. It doesn't change the pulmonary hypertension per se, but it allows them to acclimate and accommodate and compensate for the limitation that they have with the pulmonary hypertension by having improved conditioning through these formal exercise programs or reconditioning or rehabilitation programs. And pulmonary hypertension is not one of the classic indications for this intervention. Usually that's been after major heart surgery or major lung surgery, or if you have congestive heart failure or COPD. So it can be a challenge for access to care for what we know is an effective therapy for these patients. So that's often a back and forth.
I think there are several important gaps in care for patients with PH and PAH. First of all, I think we need to focus more on improving a patient's overall quality of life and how they feel related to their pulmonary hypertension, as opposed to specific endpoints like hemodynamics. Additionally, as we're getting into this era of more is better approach of treating pulmonary hypertension with more medications, we need to focus on how we can improve a patient's burden of having to take multiple medications and deal with multiple side effects as we treat the person as a whole rather than just the pulmonary hypertension itself. A more personalized approach to treating pulmonary arterial hypertension starts with a better understanding of how different subtypes respond to different treatments of pulmonary hypertension and different treatment approaches with medications such as immunomodulators and different classes of PAH therapies. Lastly, a significant gap in care for patients with pulmonary arterial hypertension remains the cost and access to medical therapy for PAH patients. If a medication is effective, but a patient cannot afford it due to the out-of-pocket cost for them, then it will not work for that individual patient.